Welcome back. This is Ian Bodrick.
And Liang Lu.
And this is the Clinical Correlation. Today's case is...
This is a 63-year-old homeless man who was brought in by EMS for altered mental status. He has a history of alcohol abuse and alcoholic cirrhosis.
It is the middle of the afternoon, and the patient was found laying on the sidewalk by bystanders, so they called EMS. The paramedics were unable to get the patient to respond. He has minimal movement to sternal rub. EMS did not get vital signs because the patient was uncooperative.
His vitals show that he is febrile and mildly tachycardic.
A quick assessment of the patient shows that he has extremely dry skin. You have someone go grab the ice packs.
Heat emergencies occur with prolonged exposure to elevated temperatures. It can occur during only moderate exposure to ambient heat, especially in high-risk patients, including alcoholics, chronically ill patients, and those taking antipsychotics, anticholinergics, or cardiovascular medications.
Heat-related illness accounts for around 4,000 deaths per year in the United States, and is the second leading cause of death in young athletes.
It is important to know the mechanics of heat loss from the body in order to understand the reason heat emergencies occur.
Radiation accounts for 60 to 65% of cooling of the body. It is heat transferred by electromagnetic waves. It is a major source of heat loss.
However, when the ambient temperature is greater than the body temperature, it is a source of heat gain.
Convection is heat loss to the air and water vapor molecules that are circulating around the body. With a rise in the ambient temperature, the amount of heat loss decreases, and at a certain point, the body starts to gain heat.
Convection accounts for up to 15% of heat loss and is affected by surrounding air velocity. Convection is the way certain home ovens work to heat up food.
Conduction is the direct transfer of heat energy from a hot object to a cooler object by physical contact, which is how things are cooked on the stove.
This only accounts for 2% of how the body loses heat, but can be increased greatly if the body is immersed in cold water.
Evaporation is when liquids are converted to gas using energy to do so. This is mostly from sweating in humans, but can be from a respiratory source as well in panting animals.
Sweating can account for up to 25% of heat loss.
In the right setting, the body's mechanisms for heat loss can be overwhelmed, leading to an increase in the body's temperature. This can occur when there is the right combination of exogenous heat gain, increased endogenous heat production, and/or decreased heat dispersion.
Endogenous heat production can be caused by febrile illnesses, increase in physical activity, and medications. Conditions that contract the muscles can increase heat production, including seizures, withdrawal from drugs, malignant hyperthermia, neuroleptic malignant syndrome, and a highly combative patient.
Some examples of drugs causing increased heat production are cocaine, amphetamines, TCAs, LSD, PCP, MOAIs, and salicylates.
Some causes for the decreased ability of the body to disperse heat are dehydration, extremes of age, improper clothing, diseases of the skin, drugs, cardiovascular disease, and obesity.
Miliaria rubra is known by several names, including prickly heat, heat rash, and lichen tropicus. It is a maculopapular erythematous pruritic rash that is typically found over closed areas of the body.
The cause is a blockage of sweat pores by macerated skin. This leads to increased pressure in the pore and eventually rupture and vesicle formation.
Treatment is with antihistamines. Antibiotics can be used if the area appears super-infected.
Heat edema occurs in people traveling from cooler to warmer environments. It typically occurs in the feet, ankle, and hands.
Fortunately, it resolves on its own. Patients can elevate their legs and wear support hose. Diuretics are contraindicated.
Heat syncope is a variant of postural hypotension and is likely a combination of dehydration, decreased vasomotor tone, and vasodilatation. It occurs more often in the elderly.
Keep in mind that this is a diagnosis of exclusion, and all other life-threatening causes of syncope must be ruled out.
Heat cramps are contractions in skeletal muscles that are painful and spasmodic. This occurs in patients who have been sweating profusely and are replacing their fluid loss with hypotonic fluids like water.
It is self-limited, and PO sports drinks can be used to treat the cramps, with IV fluids being reserved for severe cases.
Heat exhaustion presents with nonspecific findings, including weakness, fatigue, lightheadedness, nausea, vomiting, myalgias, and headaches. It is caused by decreased fluid intake in the setting of heat exposure and increased activity.
On exam, these patients typically have a fever, but usually under 40 degrees, and can sometimes not even have a fever. They will also be sweaty and have orthostatic hypotension. Mental status will be normal.
Labs will show evidence of hemoconcentration. Treatment includes electrolyte replacement, both oral and through IV fluids. Cooling efforts should be made if the temperature is above 39 degrees. Most patients can be treated and discharged. Rhabdomyolysis is a complication if not treated in a timely fashion.
Heat stroke is at the extreme end of the heat-related emergency spectrum. It is fatal if not treated and has a 30% mortality rate even if treated. The classic type, or non-exertional type, occurs over several days and is seen in the elderly and children. The exertional type is usually seen in young, healthy patients who have just gone through strenuous activity.
The patient's core temperature will be elevated, usually greater than 40 degrees, and they will also have CNS derangements, ranging from altered mental status to ataxia to seizures. It is classically taught that these patients will exhibit anhidrosis, which most will. However, if the patient is still sweating, it does not rule out heat stroke. Labs might also reveal abnormal LFTs.
The ABCs should be managed in these patients. Some will be hypotensive and usually respond to very small amounts of fluids. However, if pressors are needed, avoid peripheral vasoconstrictors, which will direct blood flow away from the extremities and decrease cooling.
Remove the patient from the hot environment and initiate cooling techniques as soon as possible. This reduces both morbidity and mortality and should be initiated in the pre-hospital setting if possible. The goal temperature is classically below 39 degrees, although there is no good data for this number. Keep in mind there is no role for antipyretics or dantrolene in heat stroke patients.
Cold water immersion is the most effective cooling technique, although not very practical in the emergency department. It provides the quickest cooling, and studies have shown close to a 100% survival rate if initiated within 30 minutes.
Keep in mind this makes resuscitative efforts difficult, especially defibrillation. As emergency physicians, we can strategically apply ice packs and get similar effects.
Evaporative cooling measures are easier to apply in the emergency department. This involves spraying cool water onto the patient and having fans directed at them.
It is slower than cold water immersion, but does not interfere with resuscitative efforts.
Know that invasive techniques such as cold water lavage of the chest cavity and peritoneum have been described. However, there is insufficient data to currently recommend these techniques.
To summarize, know the mechanics of how heat is gained and lost by the body. This will help you understand heat-related emergencies and their treatment.
There is a spectrum of heat-related emergencies. Be able to differentiate heat stroke from the rest, as this is truly life-threatening.
Know how to rapidly cool the patient, as well as the risks and benefits of each technique. So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotify.
And me at EMLLou. Thanks for listening.